Good afternoon, everyone. My name is Darius. I'm one of the chief residents, and I have the honor of introducing our grand round speaker today. We have Dr. Jonathan W. Friedberg here. Dr. Friedberg is Samuel Durand Professor of Medicine at the University of Rochester and Director of the James P. Wilmot Cancer Institute. Dr. Friedberg received his medical degree from Harvard Medical School. His postgraduate training included an internship and residency at the Massachusetts General Hospital, followed by hematology oncology fellowship at the Dana-Farber/Partners Cancer Care in Boston. Dr. Friedberg also has a Master's of Medical Science degree from Harvard Medical School in Clinical Investigation. His research interests focus on development of novel therapies for patients with lymphoma. He is chair of the Lymphoma Committee in the SWOG National Clinical Trials Network Group and serves as editor-in-chief at the Journal of Clinical Oncology. He was awarded the Scholar in Clinical Research Award from the Leukemia and Lymphoma Society, is a funded investigator from the National Cancer Institute, and has chaired the education program at the American Society of Hematology annual meeting. Please join me in welcoming Dr. Friedberg.
Thank you so much. It's terrific being down here. We've had a very long winter in Rochester. Dr. Rosenblatt remembers those winters. It's the first real winter we've had in a few years. So I think we were getting soft, but it was a real one. So very nice to see some sunshine and warm weather. I'm going to speak to you today about this disease, follicular lymphoma, which is a disease that I've studied and been interested in since I completed my training in the mid-90s. Follicular lymphoma is the second most common kind of lymphoma that's diagnosed in the United States. And the most frequent presentation is with advanced stage disease. This is one of the indolent or slow-growing lymphomas. Oftentimes, patients may present asymptomatically or with a lymph node that's seen on imaging or on exam. And historically, this is a disease that we've considered as an incurable disease, but an easily managed disease. And the improvements that I'm going to show you have really been paramount over the last 20 years, such that the majority of patients who I meet with follicular lymphoma will not be dying of follicular lymphoma. They may be dying with follicular lymphoma. It's a disease that we periodically will treat to shrink the lymph nodes down. And there's a low risk over time of what we call transformation, where the disease can suddenly become more aggressive. And not only its clinical behavior, but histologically, it becomes a more aggressive lymphoma. And that remains a major cause of morbidity and mortality in this disease. So I'm going to make the case today, and this is showing some new data as well, that I believe that the concept of follicular lymphoma and the whole paradigm has really changed, and that with the treatments that we're giving today, we are curing a substantial percentage of patients. And this has major implications, I believe, on the way that we counsel patients, the way we follow patients, and doesn't only impact the hematology oncology providers, but also internal medicine as well. So this was a manuscript that was published very recently as a review article, kind of a forward-looking piece in Blood. And I'm pointing out that what they're talking about is, what's going to be happening in the follicular lymphoma space moving forward. Opportunities to improve first-line therapy with new drugs in combination, more focus on patient-reported outcomes, because if the disease is asymptomatic and you give treatment that's toxic, that might not be good for patients unless you're really buying some long-term benefit. Circulating tumor DNA as a tumor marker is a very exciting advance, not just in follicular lymphoma, but in most of oncology. I'm not going to be speaking about that today, but we can certainly bring that up in the question period. But they also mention this defining and achieving cure in some patients in this article. And this is really to speak to the fact that what I'm going to be presenting today, I'm not the only person who's been saying this. So when I trained, this was the curve that was always presented at meetings in the lymphoma meetings. And this curve, these are three different eras of treatment. So this is what people used to show in like the late 90s, early 2000s. And the argument was no matter what you did for follicular lymphoma, whether it was alkylating agents or new drugs like purine analogs at that time, there was no improvement in overall survival. And this was a glass half full, glass half empty slide. At this time, and again, this is going back, 20, 30 years, the median overall survival was 8 to 10 years. That's what we used to tell patients. That was considered a pretty good lymphoma because a lot of our other diseases at that time had worse outcomes. But there was a bit of nihilism in the study of follicular lymphoma because although we were studying all these different things, somehow it seemed that there was a script that patients would follow. So just keep these curves in mind. It's a pretty steep fall. And you can see this is now our overall survival curve of a very mature clinical trial that has long-term follow-up. And you can see that the median is not even being met at 10 or more years, really showing that patients are living much longer with follicular lymphoma than ever before. This won't surprise any of the oncologists in the room. I think this is, very reminiscent with our experience. Our clinics are full of these patients. Now, that alone is not enough to say that we're curing these patients, but it's certainly a start to show that the progress is being made. So when you see a patient with follicular lymphoma, and I mentioned that often these patients present in an asymptomatic way, the question is, what are the goals of treatment? So ideally, when we treat something in medicine, we want to change the natural history of the disease. So in a couple of easy ways to demonstrate that would be if you improve overall survival, that's changing the natural history of the disease. And in follicular lymphoma, perhaps decreasing transformation is a reasonable surrogate because transformation often leads to poor overall survival, and it's certainly a very morbid event. Most of our studies, though, are powered to look at remission. In other words, taking away the disease on a scan. Presumably, we'd like to think that makes patients feel better, but since active disease is often asymptomatic, that may or may not always be the case. So ideally, you'd also like to show that you're improving quality of life, and that's hard to measure. And I'll show you a little bit of data on that, but our ability to really say definitively that we're improving quality of life by shrinking follicular lymphoma is limited. And most frequently in our clinics, this is shared decision-making. In other words, the patient and the clinician often have to work together, and you might approach a young patient who you want to give a very long remission to, even if the therapy is a bit more toxic. A very different approach from somebody who's in their 80s, who you just want to keep the disease down because they have a lot of other comorbidities. Now, if we're going to talk about cure today, I'm going to submit that it can be very hard to define cure in an indolent disease. Normally, if you're treating an infection, the way you cure an infection is you give a treatment and the infection goes away and you say, well, we've cured that infection. This is a disease with a very long natural history. It's not uncommon for patients to have relapses 5 or 8 years after diagnosis. So what is the endpoint to define cure? I've put up here a survival curve of a different lymphoma called diffuse large B-cell lymphoma, which is by all counts a curable disease. Everybody you ask, we would say this is a disease where the goal of treatment is cure. It's an aggressive lymphoma. If you don't cure the lymphoma, the patients usually have a lifespan of months to a year or so. And you can see that often what we look for is a plateau on the progression-free survival curve where it flattens. In other words, there are very few events that are occurring, and that's a sign that the disease is cured. Now, I'll just remind you that a progression-free survival curve, events on this curve are either death or disease progression. That's the definition of a progressive-free survival curve. Now, if you have a disease with a short natural history, you can see a flattening, but let's say that you have a disease like follicular lymphoma where the median age of patients might be 65 or 70, and a natural history that goes a decade or 2 decades, you're going to see deaths that are not from the lymphoma, but are showing up as ticks on this curve. So it may be very difficult to see a flattening of the progression-free survival curve. The other argument that is made in follicular lymphoma is, well, I saw a patient in my clinic last week who relapsed 12 years after treatment, so it's going to be very hard to say the patient is ever cured. And I'll just remind everyone that late relapses are seen in many curable diseases. Dr. Moskowitz follows patients with Hodgkin lymphoma. We know that that can relapse late. Now, sometimes when it does, if you do elegant studies, you can show it's a different lymphoma, but sometimes it really is the same lymphoma. And certainly diffuse large B-cell lymphoma, there's a whole literature on late relapses that occur. So even in the diseases that we accept curability, you're going to see some late relapses. So how do we define cure? I went back to the literature, and this was a paper from 1971. This here is a very famous oncologist, Dr. Fry, who was actually in Boston when I was there. He used to still ride his bike to work in Boston, which is a dangerous thing to do. And this is what these investigators wrote at that time. We can speak of a cure for Hodgkin's disease, which is what it was called back then, when in time, probably a decade or so after treatment, there remains a group of disease-free survivals whose progressive death rate from all causes is similar to that of a normal population of the same age and sex constitution. And they went on to say that precise estimates of cure rates can only be obtained from groups of cases that have been carefully staged, classified by histologic type, treated in a reasonably homogeneous fashion, and followed for, in that disease, 3 to 5 years. And I think in Hodgkin lymphoma, that resonates very well. In fact, when we see data in Hodgkin lymphoma that are 3 to 5 years of follow-up, we can presume that there's a huge fraction of those patients that are indeed cured. So with these definitions, let's explore a little bit about whether we are curing follicular lymphoma. I'll start with an easy one. For a long time, it's recognized that in the rare situation that follicular lymphoma occurs in stage 1 presentation, and that's a single lymph node without any bone marrow involvement. So, a rigorously staged patient with a single lymph node, we've accepted that a fraction of those patients can be cured with radiation therapy to that lymph node. I'll emphasize this is an uncommon presentation, but this is a relatively recent study that looks at a group of patients from Vancouver compared with a population-based cohort of similar age, similar 10-year overall survival. So the overall survival seems to be the same. Very few relapses after 15 years. And the event rate between years 10 and 15 is very, very low, especially regarding relapses. So it's accepted that we're curing some patients with that modality. But that's not really what this talk is about. This talk is about patients, the 80+% of patients who present with more advanced stage presentations. So those patients can be divided into 2 clinical categories based on their tumor burden. And I guess for this medicine audience, I don't have to go through all the details, but let's just say we can divide them into low tumor burden or high tumor burden. Low tumor burden is you don't need treatment. The disease was found by accident and the patient's feeling well. High tumor burden is, there's problems. They're either having symptoms, or I just had a patient with a 10-centimeter abdominal mass that isn't causing problems today, but will soon if we don't shrink that down. The most common situation is a low tumor burden presentation. And our options in low tumor burden disease, and this is a typical case, you can read it, are range the gamut from watchful waiting, meaning we don't treat until the disease progresses and becomes high tumor burden, to single agent rituximab, an anti-CD20 therapy that's highly effective at shrinking these lymph nodes down, all the way to chemoimmunotherapy with a goal of putting the disease down for a long period of time. And there have been studies that have been done that really have failed to show an overall survival benefit for any of these treatment options. Again, some of the nihilism around, early intervention of follicular lymphoma. But probably the most relevant study was this one that randomized patients with low tumor burden disease to 3 different treatments: watch and wait, rituximab, or prolonged treatment with rituximab. This middle arm ended up closing relatively early in the trial because of accrual consideration. So it really only evaluated, I'd say, the red versus the blue curve here. They published their initial paper more than 10 years ago with short follow-up. Not surprisingly, if you gave treatment, the number of events was going to be less than if you didn't give treatment. But the real information of the study really only came out several months ago when they published, more than 10-year follow-up, actually. And what you can see is that if you look at progression-free survival, the patients that were observed had a progression-free survival of a median of only 2.5 years. The patients who had the very prolonged rituximab had a median progression-free survival of 15 years. That's a fairly dramatic difference. Now, they also looked at, time to transformation, and there was no difference. So it wasn't that you were decreasing transformation risk. The transformation risk continued to steadily increase over that 10 to 15-year time frame. So again, there are different ways to interpret this. Some people would say, well, we're relatively low morbidity treatment like single agent rituximab. I'm going to intervene. And we can tell you that more than half of patients can go longer than 15 years before they need any other treatment. And if you're 45 or 50 years old, a lot of people would sign up for that. Other people would say, I don't want to give you any risk right now. There's no overall survival benefit to intervention. Let's just wait. And as the disease grows, we can intervene. And the point to make here is that a subset of these patients never needed treatment at all. So it may be that ideally you'd like to risk stratify these patients, and we're not able to do that easily. They published an accompanying quality of life comparison where they tried to at least tease out what patients preferred. And I think quality of life is very important. I'm concerned that our tools are really too crude to really address what patients are experiencing. That said, when they used validated tools, they showed improved quality of life scores in patients who got treatment compared to those who did not get treatment. And some of that had to do with anxiety about coming into the clinic. And importantly, the treatment itself was relatively low intensity, so it didn't decrease quality of life. So it's not like the patients were suffering very much for that benefit. So how do you interpret these data? 34% of the patients in the watchful waiting group had not started treatment at 15 years. So I think this is a real balance. You have an intervention that can work very well and can really meaningfully change at least the way the disease behaves over a 15-year time frame, but no benefit on overall survival. The conclusion that the authors made was that early rituximab monotherapy substantially delays the need for new treatment, confirming value for patients who seek to avoid or defer treatment with chemotherapy. So there's another data set that can inform the low tumor burden situation, and that's the RESORT trial. The design of this trial was different. This treated everybody. This did not have an observation arm, and patients got rituximab. And then after response, the patients were randomized to either a prolonged, really indefinite maintenance where the treatment was given continuously, or to retreatment at progression, meaning that the patients were observed, and then if the disease came back, they got the rituximab again in that situation. And the primary endpoint was looking for when rituximab stopped working in this patient population. And a long-term follow-up of this trial has also been completed, and you can see that at 10 years, about 30% of patients remain without any evidence of disease progression. And this is just with the single agent rituximab, no maintenance treatment. So that's with a median follow-up of 12 years, a suggestion that you can give a patient 4 doses of rituximab and a substantial percent of them, may not have any progressions. And this may be a group of patients we'll come back to that we've cured. Now, again, looking at overall survival and transformation, these strategies did not have any major differences. And you can see the overall survival at 10 years, 83 or 84%, dramatically different from that first curve that I showed you, where the median overall survival was at 8 to 10 years. This study also looked at quality of life. And, there was a small difference when you were getting treatment around anxiety, but otherwise there was no measurable difference in quality of life between these two strategies. So in the low tumor burden situation, how do we synthesize and put all this together? I think we can say with confidence that the overall survival is clearly better than in the past. There's no survival benefit or decreased transformation risk that's been demonstrated with early intervention. I'll acknowledge that. However, many patients who receive limited rituximab dosing have prolonged remissions and improved quality of life. So the definition of management remains complex, and you have to consider all of these things, whether remission in a given patient is a surrogate for clinical benefit, the cost of these treatments, whether it's financial, the physical cost of coming into clinics, the emotional cost of getting hooked up to an IV, as well as treatment-free intervals. And there's some patients where, if you can give them a relatively low intensity strategy and say, I'm going to buy you 10 or 15 years where it's unlikely you're going to need anything else, they would definitely sign up for that. We're in our group. It was mentioned that I chair the SWOG Lymphoma Committee. I have that role for another 2 days. And on Saturday, I'm giving the reins to a colleague. But we've designed and are accruing to this trial, which is enrolling patients with low tumor burden follicular lymphoma. And the control arm is the single agent rituximab strategy, given in an extended schedule. So it's over an 8-month period of time, so a defined duration of treatment. And we're comparing that to a bispecific antibody. And the question is, what is a bispecific antibody? So mosunetuzumab is an antibody that not only binds to the tumor cell, but also binds to a T cell. And it physically brings the T cell up against the tumor cell, and that dramatically accelerates the killing of this cell. And the efficacy of mosunetuzumab is quite high, even in patients that are refractory to rituximab. It also is got a bit more side effects, but it's not chemotherapy. And for the most part, after a ramp-up period is quite tolerable. And I think the question and what this trial is trying to ask the question is whether with an earlier intervention in low tumor burden patients, these strategies may be a curative approach for some patients, particularly when you add mosunetuzumab. All right, so getting closer to the stronger argument toward cure, I'm just going to briefly set the stage for high tumor burden follicular lymphoma. This is patients who come in the door and need treatment, where they're having either B symptoms, fever, night sweats, weight loss, large adenopathy, cytopenias, and follicular lymphoma can certainly do that. Or these may be patients who were initially diagnosed with low tumor burden, were observed because they weren't treated initially, and have now gained enough tumor burden where you feel you need to intervene. And as I mentioned on the previous slide, the standard approach for these patients has been chemoimmunotherapy, combining chemotherapy with an antibody. And there are a number of different strategies that have been studied. Some of this goes beyond, what I'm talking about in this talk. But, this representative trial called the Gallium trial looked at 2 different antibodies combined with various chemotherapy regimens. And you can see that these antibodies with the chemotherapy can accomplish most patients being responding. So response rate is, well over 80%. And the 2-year progression-free survival is between 80 and 90%. And a subset of these patients have durable responses, and that's what we're really going to focus on. And what this is trying to show is, again, with quality of life, it doesn't matter which antibody you got, the quality of life got better, and very quickly it gets better, even during treatment, which makes sense because these are patients with high tumor burden. And quickly the disease is shrinking and those symptoms that the patients had are going away. Now, there's a cost to these treatments. And when you give chemotherapy, you can get immunosuppression. Here's an example of T cell counts over time. And you can see that the T cell counts, particularly patients getting bendamustine, do go down. And if you measure T cells in these patients, they may be at AIDS levels by the end of your treatment. And in some patients, that can be last for months to a couple of years. And that does sometimes set these patients up for opportunistic infections. Some of those can be prevented with antibiotic strategies and antiviral strategies, but I think that it suggests that we have to be very careful that as you dial up the efficacy, the toxicity goes up, and some of these toxicities go beyond the acute phase. That said, with long-term follow-up, and I showed this curve before, the overall survival is really something that we never would have dreamed of 20, 25 years ago in treating follicular lymphoma. And the progression-free survival here, you can see there remained an advantage of the obinutuzumab. That advantage is small and, again, not probably worth a lot of time in this discussion. But you can see that the majority of these patients are going out more than 10 years without any evidence of disease progression. Now, one other study to help set us up for this is to trying to alternatives to chemotherapy. So this was a randomized trial that compared chemoimmunotherapy, which is the standard that we've been talking about, to lenalidomide, which is an immunomodulatory drug with rituximab. And this was an exciting study when it was designed because the idea was follicular lymphoma is a disease that's a relatively indolent disease. We want to get rid of chemotherapy. No patient wants to sign up for chemotherapy. And in fact, at the long-term follow-up of this study that was just online in Blood this year shows that progression-free survival of those two strategies is the same. So that's remarkable. Maybe it's a victory. Maybe we don't need to give chemoimmunotherapy. And this is to make the case for the lymphoma people in the audience that this was a pretty representative population. 40% of the patients had disease that measured more than 7 centimeters. 49% had high-risk FLIPI. These are a relatively representative group. It wasn't cherry-picked for patients that were more favorable who might respond to the non-chemotherapy approach. And again, the overall survival curve here also looks similarly excellent. Now, so the question is, should this replace chemoimmunotherapy, this strategy? And there are two problems with that. One is that the chemotherapy control arm was up to the investigator, but there were multiple controls that were used. And you can see that when you did the subset analysis, the bendamustine group favored patients that were treated with the chemoimmunotherapy over the lenalidomide-based treatment. Now, this is a subset analysis. We probably shouldn't make definitive conclusions based on this, but I think a lot of us who use bendamustine routinely have given some hesitation that if it were a head-to-head comparing bendamustine chemotherapy versus the lenalidomide, probably the chemoimmunotherapy would have won. And that's shown here as well, just showing you that if you look at the lenalidomide arm, which is buried in to this R-CHOP curve here, if you look at the bendamustine patients and split them out, they're doing a bit better. The other reason why lenalidomide has not replaced chemoimmunotherapy, though, is that even though it's not chemotherapy, it is not non-toxic. And in fact, the percentage of patients with high-grade adverse events was similar between the two groups. Deaths were the same. And if you looked at withdrawals from the treatment, they were 3 times higher in the lenalidomide arm than in the chemotherapy arm. Part of that's because the lenalidomide arm in this study went for a long period of time. But the message was that I'm not sure the patient experience is necessarily that much better. And outside of a few institutions who helped develop the lenalidomide regimen, I don't think too many people have widely adopted this strategy. All right, so finally, this is just one last study that was published last year in Europe that compared the lenalidomide rituximab to rituximab alone, and you can see that there seems to be a flattening of progression-free survival in the addition of lenalidomide. All right, so now I'm just going to date myself for a second and ask somebody to yell out, do you know who this group is here? Anybody?
Culture
The
Club.
Cure.
The Cure. Thank you. Somebody online woke up with a yellow background. So this is The Cure. So this is what I'm going to discuss and make the argument that, in fact, with these strategies that I've briefly reviewed, we are curing patients with follicular lymphoma. So this was the results of a manuscript that we just published last month, looking at 15-year follow-up of this clinical trial. And I think that this story is going to tell the power of clinical trials. This is a federally funded trial. The importance of very long-term follow-up in a disease like follicular lymphoma. And the irony here, and this is maybe some incentive for the young investigators in the audience, is that this was a negative trial. So the primary endpoint readout of this trial actually was a negative trial. And now 15 years later, we're still learning significant amounts from this trial, so that a well-designed trial, even if it's negative, I think can have major impact on the way we take care of patients. So we concluded in this, and we'll see if you agree, that the results of this secondary analysis suggest that a subset of patients with advanced stage follicular lymphoma can achieve cure, and that this finding represents a paradigm shift in the understanding of an approach to follicular lymphoma. So here was the design of this trial. This was a randomized trial. Initially, there was a CHOP alone arm that closed quickly because standards had changed. So half the patients got CHOP with rituximab, which is still a reasonable standard today. And the other patients got CHOP with a radioimmunoconjugate, iodine-131 tosatumumab. This is not a treatment that we use anymore, although as you will see, it's a very highly active treatment in follicular lymphoma. There was no maintenance therapy given here. The primary endpoint here was progression-free survival. And I do want to just call out a luminary in the field who designed this trial, Oliver Press. Ollie Press died tragically of a brain cancer about 10 years ago, but he was extremely passionate about this trial. And I can only say, and I'll look at my lymphoma friends here, that he would be so proud to know that the results of this trial continue to inform practice this far after designing the trial. So these are the patients that we enrolled on this trial, and this is to really make the argument that this is another trial that was a representative group of patients with follicular lymphoma. These were not highly favorable patients. They all had advanced stage disease. We had intermediate and high-risk FLIPI scores in the majority of patients. Majority had bone marrow involvement, and our definition of bulk disease was 10 centimeters, and about a quarter of the patients had that. Now, as far as quality of follow-up, with a lot of work, 90% of the living patients have more than 10 years of follow-up, and half of them have more than 15 years of follow-up. So these patients were really tracked carefully. Scans were required by the trial in these patients through year 7, which is a much longer scanning period than in virtually any other study that was done. And I'll just submit, in those diseases that we consider curable, like large cell lymphoma and Hodgkin lymphoma, we don't scan patients for much more than 2 or 3 years. So the outcome of this at 15 years, the top curve is overall survival and the bottom curve is progression-free survival. I'm pooling the two groups because the point to make here is more about the overall outcome than the individual outcomes. At 15 years, the overall survival was 70%, and the progression-free survival was 40%. Interestingly, with longer follow-up, there was a benefit to the iodine-131 tosatumumab. Unfortunately, there was toxicity associated with that arm, including some increased risk of leukemia and myelodysplastic syndrome, which is probably the reason why we're not using it anymore. Now, at first glance, you look at this curve, and it does not look like a progression-free survival curve that is flattening out. So that would, at first glance, mean that this is the same story that we're seeing over and over again with follicular lymphoma. This is a disease that inevitably there are going to be continuous events. But let's dig a little deeper. So the causes of death on this trial are shown in this table. And you can see that lymphoma deaths are only about half or less of the deaths that are occurring in these patients. Medical issues other than cancer, second malignancies are often maybe not even related to treatment. These are patients that are older. And the idea is that when you're dealing with patients, as I said previously, that are enrolling at age 65 or 70 and you follow them for 15 years, they're going to die of other things. And if you take a look at that in a more specific way, you can see here that if you take death without progression as a competing risk, so if you die of a heart attack at year 12 because you have an aortic valve problem, that's probably not related to the lymphoma. You can see that there is a bit more of a flattening out of this curve, whereas on the bottom, the deaths from other causes just continue to increase and increase. Now let's look at this in a little bit more detail. If you look at the average progression rate per year, in the first 5 years, it's 6.8%. The majority of the progressions, if they're going to happen within the first 5 years. That number is halved between years 5 and 10. And then after year 10, the rate of progression per year is very low. And particularly after 15 years, it's really negligible. So there is a flattening out that's occurring. And, put another way, if you're seeing a patient in your clinic at year 12, they've been treated with R-CHOP for their follicular lymphoma 12 years ago, they have only about a 1% chance of that disease coming back. In other words, they have a 99% chance over the next year that there would not be any disease progression. That is substantially better than the patient with diffuse large B-cell lymphoma who we're seeing at year 4 and telling them that they're cured, or year 5, because there is a late relapse risk in that disease as well. Yet we've been very hesitant to use the word cure in this disease. So we have to go beyond, though, the flattening of a progression-free survival curve, even if we take out these deaths, and really to go back to that definition of cure, to compare this to what you'd expect in a normal population. So we compared the hazard rate, in other words, the event rate, with age-matched controls. And these were very carefully selected controls from the period of time that the patients enrolled on the trial, because the mortality rate in the year 2000 when they enrolled was different potentially from now. And basically, the risk of lymphoma-related events approaches a level of general population by 20 years that supports the concept of cure in a proportion of patients. And you can see that the excess hazard rate after about 10 years is really very low, and it's almost zero by year 20. We then performed formal cure modeling, and this is an exercise that is done statistically when you have and you accept the concept that a proportion of people are likely to be cured, and there's a proportion of patients who are not likely to be cured. The presumption is that at baseline, there's a difference between those two groups. And you can therefore accept late relapses because you say that just because somebody's made it to 15 years, if they're in the non-cured group at diagnosis, they're still at risk for relapse. But if they're in the cured group, they're not going to relapse. So there are two types of modeling that's done. We use the mixture cure model. If there's statisticians in the room, I can speak a little bit to why we chose this one, but this is considered the most robust model for that cured population. We presumed the cured population would die at a background mortality rate of the US population. And we did not, therefore, assume that censored patients would not experience future events. And when we did this, we showed that the overall cure rate in this study was 42%. If you look specifically at the patients treated with R-CHOP, it was 35%. So that's different from the progression-free survival, and in part that's because there's still going to be a few events that occur, and of course the patients may be dying of other reasons. Of course, we tried to say, okay, can we characterize who these cured patients are? And somewhat not surprisingly, it's the lower risk patients that have higher cure rates. So if you just look at the split of beta-2 microglobulin, the half of patients that had low or normal beta-2 microglobulin had a 55% cure rate in this study, whereas only 31% of those with high beta-2 microglobulin were cured. Obviously, we'd like to look at more robust molecular predictors of this cure fraction. I'm going to put it to the question and answer if you're interested. I suspect that's going to be very hard to do. We've been trying for more than 20 years to define the high-risk group of follicular lymphoma patients, and our best measure still is a clinical definition of somebody who relapses early. So the flip side of it to define the cured population, I think, is going to be equally hard. Now, you submit this to a journal. I'm an editor of a journal, and the first thing somebody says is, well, let's say you missed a relapse, right? You only followed the patients with scans for 7 years. How do I know that, Mrs. Jones, who's in Tulsa, Oklahoma on this trial, hasn't relapsed and it's an asymptomatic disease? You got to be very careful using the term cure. So we can't say for sure what happened to the patient in Tulsa, Oklahoma, but we could do some modeling and say, well, let's say that we missed half of the relapses. The message on this is that if there were 50% more additional events between years 10 and 15, and 50% more additional events between years 15 and 20, the cure rate on the study is still 33%. The number of events that are happening at these late time points are so low that you could go all the way down and double those events, and you're still seeing a fraction of patients that are cured. And I think that, if anything, makes some of the strongest arguments that we are curing patients with follicular lymphoma with advanced stage disease. It's taken us 15 plus years in the rituximab era to recognize this in a definitive way. But this is important because we know that the cure rate is highest in patients with low-risk disease. And this suggests that patients may be referred to primary care teams after 10 years of follow-up. And I've been doing this. Our clinics are full of these patients. If a third or more of patients that we treat with chemoimmunotherapy with follicular lymphoma make it 8 to 10 years out, I say, we're done. If something happens, I'm always here. But the chances of me picking something up on a conversation and a random physical exam a year from now is so low that it's not worth you coming back to the cancer clinic. I mentioned that these results, I think, emphasize the importance of long-term follow-up. And I just want to revisit one other component, and that's say that the concept of cure in follicular lymphoma is really not new. If you look at the autologous transplant data, we don't really do a whole lot of autologous transplants anymore in follicular lymphoma. But whether you did that modality upfront in high-risk patients in the pre-rituximab era, or in relapse setting in the pre-rituximab era, in younger patients, there was a plateau on the progression-free survival curve. And 20 years ago, our colleagues from MD Anderson were giving this very aggressive regimen called alternating triple therapy. It was a lot of chemotherapy, that's all I'll say. But they looked at long-term follow-up and wrote that the apparent plateau in the failure-free survival curve, starting approximately 8 to 10 years from the beginning of treatment, raises the issue of potential curability of these patients. And they've gone on very recently to update this, showing that a large percentage of patients with aggressive regimens are remaining failure-free. So I'm most excited about the data in relapse disease with some of our new agents. We're seeing with the bispecific antibodies a fairly abrupt plateau that's forming on progression-free survival curves. And we're showing the same with CAR T cell treatment. And when you look at CAR T cell treatment in a similar way to what we did, if you take out the competing risks, there is a flattening. I will say for CAR T cell treatment, though, it's very difficult to define a competing risk because the treatment itself is so immunosuppressive that it may generate some of those deaths. That said, these are regimens that are being now studied up front in high tumor burden disease with a goal, I think, ultimately to cure more patients. So I'll conclude with just a couple of outstanding questions. So the first is that our data set gave this regimen called R-CHOP. That includes an anthracycline, which a lot of people, myself included, don't really like to use for most patients with follicular lymphoma. Would we see similar results at 15-year follow-up with bendamustine-based chemoimmunotherapy? I think yes. But, we don't know for sure. I can argue why I think yes. The results at 10 years look so similar to better, as I showed you, that it's probably a little better than R-CHOP at 10 years. It's hard to believe there's going to be a crash on that event curve, but we don't know. Obviously, we'd like to find, with genomics or microenvironment studies to define the cured population. We got people working on that. But I think it's a very complicated area in this disease. And finally, and the reason I spent time at the beginning of this talk talking about the low tumor burden, I was trained in a very conservative environment, and we always observed our patients with low tumor burden follicular lymphoma. If we're curing the highest risk patients with intervention, the principles of oncology would be that you should treat earlier, and we should maybe be treating these low tumor burden follicular lymphoma patients a bit more aggressively with a goal of curing them rather than wait till the disease is advanced and try to clean up at that point. And that's a big paradigm shift in the field, but I think it's one that we all have to entertain. So I'll just acknowledge my SWOG working group here. They're the committee that really did this work, and the cure rate study was really done by Maziar Shadman and Mike LeBlanc, our statistician, our lymphoma team in Rochester, and thank you so much for this invitation.
Thank you, Dr. Friedberg, and congratulations for your recent publication, which was so interesting. Just first an observation and then a question. It seems as though looking at the lymphomaologists in the audience that the disease-free progression seems to be proportional to the tenure of a lymphoma specialist as opposed to a solid tumor oncologist whose tenure is more like their disease in terms of staying in one academic place. I can say that with certainty as the chair. A question I have sort of in general is if you're presented with a patient that has high tumor burden, what characteristics would sway you to treat a naive patient with something other than the standard protocol?
Yeah, so I think the biggest concern that most of us have in somebody who walks in with high tumor burden is, are we missing some occult transformation? Because sometimes patients get a biopsy with a needle of one lymph node, and you look at their PET scan, they've got disease all over the place. And if there's any clinical concern about an underlying transformation, the paradigm of treatment is different and the prognosis is different. So you would either rebiopsy or consider going down that track. And then I think it's a very individualized decision. I mean, I've been talking about the patients who deserve a more aggressive approach, but there may be older patients with follicular lymphoma that you wouldn't rush to give chemoimmunotherapy. Knowing that you have some of these novel agents in your pocket, you might start with a more gentle approach if somebody were in their 80s or 90s and had other comorbidities. And that's not a foreign patient population to us. I have two active patients that I'm treating right now, one who's 96 and the other who's 98. And it's remarkable how with some of our new tools, we can get patients like that through treatment. And, I've said to the patient, if you want to stop, you just tell me. You call the shots when you're 98 years old. But she's somebody who's still living rather independently, and stopping would have caused a lot of morbidity from her lymphoma. So I think those are some groups that I might think about a different approach.
Dr. Moskowitz. Wait a minute. Wait until I get you the microphone so the people online can hear.
First, I'm not a Cure fan, but I do wear an Iron Maiden button. So I think, of course, the talk was elegant as always. And I would say those of us who are more mature, who take care of lymphoma, would agree that there are certainly patients with follicular lymphoma that are cured. I think the other important question, which you stated early, is that a third of patients never need to be treated. I have patients, and I think all of us do, though, I discharge these patients, just don't come back. If nothing has happened the next number of years, call me when you need me. So are the cooperative groups or anybody that you know really trying to tease out the patient who will never need to be treated? Because it's quite a number.
Yes, it is. And I think, that's what that watch and wait study showed, is that, up to a third of patients, it's not a third of patients with follicular lymphoma, but a third of patients with low tumor burden presentations, come in. And that may be, a sixth or a seventh of patients with follicular lymphoma. So, I mean, it's a meaningful number for sure. I mean, those are very hard studies, of course, to do because particularly if they're not on an active treatment, the schedule of follow-ups is somewhat arbitrary. You're likely going to learn the most from registries. Miami participates in the LEO consortium, which is one such registry that is banking tissue and trying to follow patients observationally, and there will be a subset of patients there who have good outcome. The problem is that even in a center like here, how often those patients are seen and imaged, and the quality of the follow-up is somewhat limited. So definitively knowing that, those patients haven't required treatment can be a challenge. And then, as I said, what we'd all like to do is to say, okay, what's the genomic signature of a patient who either with single agent rituximab or nothing doesn't ever need to go on to chemotherapy? It's been so hard in follicular lymphoma to do that. Very briefly, it's an oligoclonal disease. So, the clone that you may see and do your genomics on may not be the clone that ultimately causes relapse. So understanding, maybe circulating tumor DNA will get us through that. And the contributions of the microenvironment are likely critical. And although there's a lot of elegant science, translating that elegant science to a clinical actionable test, I think is going to be a long time coming, unfortunately.
Dr. Losos.
Jonathan, excellent presentation as always, and congratulations on the recent publication. I will ask you more philosophical, or I will make a statement more philosophical. Is cure is important in this disease? That's a major issue because we all see patients that are relapse-free, doing well 15 years, and suddenly they come that you already discharged them or telling them to go away, they're not going away, and suddenly they're coming, and there was a relapse. In follicular lymphoma, in contrast to other diseases, the relapses are more commonly is the same disease based on molecular studies. So, and it's not uncommon that patients will relapse, and because we don't do scans and we cannot examine certain areas of the body on physical examination, that they may be living with slowly growing or even not growing or stagnant tumor there for many, many years. So the cure is more hypothetical, but the most important thing that you showed here clearly, these patients are living significantly longer than they used to live with current therapy, and most probably they will live even longer with new therapies. And many of them are not different from general population. So I don't know if to use cure, but the fact that they're living the same as general population is the major achievement that we achieved in follicular lymphoma.
Yeah, I mean, I think you're right. We should question whether this word cure, how important it is. I would submit that for most patients, at least at the time of diagnosis, if you can tell them they have a curable disease and we're going to give you a treatment and it's going to go away, it is a different calculus from you're going to be getting to know me really well and you're going to be in here. You'll probably live a normal lifespan, but that label of cancer that is hovering over you, I think, can be very challenging. Now, we support patients through that. Many patients 3 to 5 years later may have a different outlook once they kind of accept all of this. But I think that, and the other point to make is that, the cost of treatment measured in many ways over that 15-year period of time can be substantial and will only go up financially, at least with our new tools. So it feels to me like if there are few opportunities that we have in cancer medicine where if you have a definitive curative therapy that you wouldn't try it. I agree, though, it has to be balanced against morbidity always in this disease.
Dr. Schatz.
Thanks for coming down to see us. It's great to have you here. It's sort of along the same lines on the quality of life data. When you compared the watch and wait versus the rituximab plus maintenance group, some of the patients in watch and wait, is some of that driven by the fact that they then progressed and had to get treatment? And those, if you broke out only the ones who never progressed and compare it to the rituximab plus maintenance, was the difference that big? I'm asking sort of because I have a lot of patients on watch and wait. I want to make sure I'm not psychologically torturing my patients unnecessarily.
Yeah. Well, fair enough. And I will say that it's been I'll answer my personal clinical experience that oftentimes I would spend a long time trying to reassure a patient that it's okay to not treat you. I mean, we've all experienced this, right? It may take 2 or 3 visits, but I'm feeling this. They'll call, the lymph node grew and it went from here to here. Many of those patients in my personal experience eventually accept this. And by the end of when they need treatment, it can be hard to convince them to get treatment, right? I mean, they're the ones that they say, oh, let's wait another 6 months. Are you sure we have to start? So I think that it's certainly my personal experience that with time, people can accept things as they develop a strong relationship with their care teams and understand the disease. The measurement here, I think you're right. I mean, part of it is that you lose patients who are having events on these studies. I think the best measure of that is the resort trial in some regard, because there everybody got treated and the study didn't end until the Rituxan stopped working. So half the patients got long Rituxan and presumably were in remission, and the other half were getting Rituxan as needed. And both of those strategies, from a quality of life, as crude as the measures are, appeared to be the same. So I don't think that you're negatively impacting patients, except for maybe during the acute education phase.
I want to thank our illustrious Grand Round speaker today, Dr. Friedberg, for being here. I want to remind everybody to check the chat or the QR code on exit to claim CME and MOC credit. I wish everybody a great day, and we'll see you next week. Thank you.